And at this point in the Explainer, we get into the conversation this World Cancer Day. But allow me to set the stage. And Kenya joined the rest of the world in marking this year's World Cancer Day under the global theme, United by Unique. My panel will help explain what that theme is all about, which highlights the value of individualized, patient-centered care in the fight against cancer. The government has been called upon to ensure easy accessibility of cancer services to ease the burden. Emily Chebet kicks off our conversation.
Margaret Thithi is one of those who joined other Kenyans and the world in marking World Cancer Day at the Kenyatta University Teaching and Referral Hospital. For her, this day has a lot of significance. In 2016, she was diagnosed with breast cancer. Almost 10 years later, she can afford a smile.
Nilianza matibabu, nikafanywa chemotherapy 6 na radiotherapy 25. Sasa ni review na kujaga, juu na kuja review clinic, daktari wananiambia hawapati cells. Sasa daktari wameshaniambia I'm cancer survivor.
There have been concerns across the world about the rising burden of cancer, posing serious challenges economically and mentally to families affected. As the world marked the day, Kenyans were urged to frequently go for testing to enable early detection.
Mimi nilianzia na kusikia niko na uvimbe kwa matiti. Nikaenda kwa daktari, nikajulikana niko na kansa. Sio rahisi, ilikuwa gumu sana. Juu ya sapoti ya familia yetu, watoto wetu, wale tumezaliwa na wao, marafiki zangu akanishikilia mpaka hapa.
Cancer diagnosis, treatment, cancer control, prevention is part of those specialist services that contribute towards universal health coverage. And that we will not achieve universal health coverage if any of our patients are left behind in terms of accessing these services.
Cancer patients have been complaining of challenges when it comes to access to care, especially during the transition from NHIF to the new medical scheme SHA. But the ministry says officials are working hard to ensure care for all cancer patients.
Some of the drugs that we don't have, it's not because we are not able to buy them, it's because they are not available in the national supply chain. For example, for breast cancer management, we had shortage of Herceptin, and I think this has been even highlighted nationally, but we worked with our Kenya Medical Supplies Agency, KEMSA, and as of last week we were able to get some supply.
World Cancer Day is marked to raise awareness across the globe. Emily Chebet, Citizen TV, Nairobi.
All right, I'm joined in a studio this evening by Dr. Helena Musau, who is a consultant radiation oncologist, and she'll delve and help us understand, because an oncologist, it's, as I understand it, is a person who diagnoses and gives a treatment plan, right, for cancer, but you'll explain more. Let me also introduce the other panelists, Dr. Timothy Olwen, Chair, National Cancer Institute of Kenya, and Dr. Tracy John, Teresa Tracy John. She is the Acting Director, SHA for Benefits and Claims, and she is also a neurosurgeon. And I've seen several interviews you've done on brain tumors, so I have a very competent panel. Already several questions have been raised in that report by Emily Chebet, but we'll go, point by point. One of it is drugs availability. I saw that there, as well as support. But before we get into that, perhaps Dr. Olwen, you can tell us, where are we as a country in the fight against cancer?
Okay, thank you very much for inviting me to this panel. First of all, I'd like to say hi to all the viewers and wish them a happy World Cancer Day. It's a day when we honor and we remember all those who are affected by cancer, and I use the term affected as opposed to afflicted, because cancer has got wide-ranging impact, especially psychosocial impact, not on just the patient, but also those around them. And the theme this year is United by Unique. It is an appreciation of, first of all, the unique nature of the experience. There's no single patient who has a similar experience to somebody else. And then united because we are marshalling our collective efforts in terms of making sure that we improve everything in terms of cancer care and patient welfare.
Mm-hmm.
Yes.
All right.
So in terms of where we are in terms of cancer in Kenya, the burden of cancer in Kenya is still pretty huge. It is estimated that we've got almost 45,000 new cases every year, and we have about 30,000 deaths a year. And I must emphasize again that that might even be an underestimation, because I don't think the data that we have is fully captured, and that's one of the challenges we have, which we're trying to address in terms of updating our cancer registry so that we've got data that can inform policy and help decision making. But by and large, we've got 5 types of cancer which are predominant. The bulk of them is going to be breast, cervix, breast and cervical cancer, prostate cancer, colorectal and esophageal cancer. So those are regarded as the big 5, and in fact, if we could marshal our efforts and make sure that we are able to prevent and effectively manage these, I think the impact to our population would be great. Yes.
Dr. Musau, what do you make of the theme this year, United by Unique, such that as much as we're all committed in the fight against cancer, each person's case is unique? And Dr. Olwen uses the term affected because it doesn't just afflict a person, it affects a community.
Definitely. I think it's a very apt theme. The previous World Cancer Day theme was closing the care gap, where we were looking to ensure that we had enough resources, enough support for cancer patients to be able to achieve good outcomes at the end of the day. This year's theme, United by Unique, is quite apt, and I believe it enables us to understand that each cancer patient's journey is totally different from the next. We always say that cancer is a spectrum of diseases, so no one cancer is the same as another, and so each person's experience will be unique depending on what sort of cancer they have, what stage they have, what sorts of treatments they're able to get and access at the end of the day. Yes.
Another big aspect of the theme this year is patient-centered, person-centered care. Dr. Chiza, what's your interpretation of that?
Thank you very much. In terms of looking at the services offered from a point of patient-centeredness, this looks at trying to shift the kind of care that we provide to our patients, and especially those who are affected by cancer, from a point of view of what really concerns them. How do they see it from their perspective? Because sometimes we may be too focused on what we think is the main issue, or from our scientific perspective, while forgetting that there are other details in there that are affecting this particular patient or those around them that they feel needs to be addressed. So when we shift to that patient-centeredness, then we are able to address the issue holistically from a scientific perspective, as well as from the view of the patient and those around them, so that there is more satisfactory care provided. Yeah.
Dr. Olwen, you've given us a picture of 40,000 new cases a year, 30 deaths, I think you said, and you said these figures are conservative estimates. You've also talked about the big 5, the breast, cervical, prostate, colorectal, esophageal cancer. But where are we in terms of accessibility to cancer care across the country?
Accessibility, I think significant strides have been made in the last few years in terms of people being able to access cancer care, both in terms of the infrastructure, and I say infrastructure broadly, meaning human resource infrastructure, as in the personnel required to take care of patients, the physical infrastructure in terms of facilities that are required, medical products and technologies that are required to take care of these patients. So there's been a lot of progress made. However, there still exist a lot of disparities, especially regionally and especially socioeconomic disparities, and these arise mainly because of the distribution of healthcare workers, but also in terms of ability to pay. And so you find the range of people who get care. There are people who can get care within this country and out of the country, and there are some people who cannot get almost any care at all. So those are the things, the disparities that we need to be able to try and correct. And even as a National Cancer Institute, that's one of the reasons why the World Cancer Day celebration this year is being held in Turkana, because we are trying to also make sure that people in those underserved communities can be able to access cancer care. So we're providing screening, increasing awareness, and those are the efforts that we have to coordinate in terms of providing leadership, oversight, and coordination of activities as the National Cancer Institute. But of course, there are a lot of players in this sector. Government, of course, government has got a major role to play, and all the other people, whether the private sector, the faith-based sector, the people in the academic institutions, and so on.
Dr. Musau, speaking as somebody in the trenches, where are we in terms of access to care? Do I have to travel from Turkana, where this year's commemoration is being held, to Nairobi to get tested, to get treatment? Where are we in terms of accessibility?
So unfortunately, we are not where we should be, and we do still have disparities in terms of care. Most of our cancer centers are still within urban areas and not in the rural community. As Dr. Olweni has said, a lot has been done. Initially, I think the flagship cancer center was Kenyatta National Hospital, and then we got Moi Teaching and Referral Hospital over time, and now we have the Kenyatta University Teaching, Research and Referral Hospital as the level 6 hospitals. But we do have regional cancer centers, some of which are comprehensive cancer centers, such as Mombasa, Garissa, and Nakuru. And then we have the cancer centers that just provide chemotherapy and are not comprehensive. I think about 11 to 13 of them across the country. They still cannot cater for the entire population or the entire burden of patients with cancer. We are working very closely with the Ministry of Health in terms of ensuring that at the primary healthcare level, patients who are suspected to have a cancer diagnosis can be referred upwards to the area where they can be able to receive cancer services. And ensuring that that channel of communication is maintained so that we do not have system delays within the healthcare system, within the healthcare space.
At this point, I'll bring you in, Dr. Tracy Joy, and I see you smiling at me because you know what question is coming next. Where SHA is concerned, there have been a lot of complaints that approvals are not timely, and cancer is something that requires timely management once it's discovered. Where are we in terms of streamlining the systems, in terms of referrals, as well as approvals of procedures where cancer is related, is concerned?
Thank you very much, Olive. In terms of the Social Health Authority and management and timely management of cancer, this is something that is very important to the organization to make sure that we do achieve what we're trying to do in terms of, in addition to putting in the resources that are required, the financial resources that these patients require, also to make sure that the care is provided when it is needed. And the timeliness of delivery of service is very, very important. And these are some of the things that have really informed the kind of shifts that we are looking at, starting all the way from something like digitizing the system that the Social Health Authority is using to make sure that care is provided in a timely manner. Because with digitization, you can imagine a patient is waiting at a facility somewhere and they need care, and they need maybe to be admitted or they need to be started on treatment. With digitization, this has really brought important changes into how the health financing at the authority is done. Because from where the patient is and where the provider is with the patient, that information is able to be relayed to the institution in real time. And what that means is you are able to check all the parameters that you need to check in a very short time compared to probably where we are coming from. And these changes of improving on the timeliness, the visibility, the patient is able to know in a very short time, am I eligible for this financing or for access to this kind of care, and how much am I eligible for, and when can I get my treatment or my diagnostics done. So yes, I understand that from the time the authority was rolled out, that is the 1st of October last year, up to now, we have really made strides ahead in terms of streamlining that timeliness to care. So, and where we are going, we are moving towards even a more efficient ways of delivering, making sure the patient receives these services in a timely and efficient manner. Yes.
All right, we'll get into more detail on that. But something that has arisen, of course, in terms of access to care is the cancer centers. You've told us about Kenyatta University being the premier MTRH, KU, but you've also talked about the other centers. But you've talked about the gaps that exist. For example, you did mention Mombasa, if I heard you correctly, Dr. Musau.
Yeah.
What efforts are being made, Dr. Lweny, by government to bridge those gaps?
I think a lot of efforts have been made in terms of being able to expand the range of cancer services that people are able to access countrywide. I also don't want to create the impression that you must have a comprehensive cancer center in every part of the country to be able to deliver effective cancer care. The key thing at National Cancer Institute is to ensure that the centers that do exist actually deliver the care that is of a quality that makes a difference for our patients. What is important is that people are able to access that care, whether it means they are being referred upwards and end up at that cancer center, or whether they're going to get the cancer center close by. But the key thing is make sure that we resource all these cancer centers to the extent that they provide the quality of care that our patients deserve. One of the principles of UHC is providing care, all right, access to care. But it's not just access. It has to be access to care of a quality that is sufficient to be effective. And that's what becomes important. Otherwise, you're just providing access to care. And that becomes even more dangerous in the cancer ecosystem or the cancer space, because if you, for example, get misdiagnosed at your first visit and during the earlier days of your cancer journey, it might jeopardize your range of options in terms of treatment at a later date, or the outcome, or your survival. So what we're emphasizing here is we're expanding that range, but of course within the resources that are available. One of the things we have is that personnel are scarce. If you see the data in terms of specialists, the oncologists that we have, the numbers are extremely small, right? But we have to work with that. And so at the end of the day, first of all, we have to make sure that whatever personnel we have are able to deliver cancer care, so to speak, to the extent that they can, and refer those patients in a timely manner so that they can be able to access specialists where they can.
How are you addressing that? What recommendations would you make, Dr. Musau, in terms of addressing this scarcity of personnel that Dr. Lweny is talking about?
Okay, so I believe majority of the cancer specialists in the country were trained outside of the country. So we are now gearing towards training locally. And so in the last few years, there have been programs that are able to train locally. So we are going to be getting more and more specialists as the years go by. That said, majority of them still prefer to work in urban areas. And so we need to create avenues to entice them to work in the rural setups, whether it be increased allowances or things like that. Then, of course, encouraging people that the healthcare field is still worth it. I think there's been a lot of talk that, there's a lot of strife within the healthcare system, but it's still a calling and it's still service to humanity. And especially for patients with cancer, there's a lot more that goes in other than the science that we need to provide to these patients. Yeah.
All right. In terms of, one of the big issues where cancer is concerned is the earlier you diagnose, the better your chances, right? So where early diagnosis is concerned, what provisions are made under SHA for screening, for instance, Dr. Tracy John?
Thank you. Indeed, as you've put it, screening, the whole spectrum of care for the cancer patient is very important, and that is why in this new initiative, or in this system that we have under the Social Health Authority, we looked at making sure that this patient who either is predisposed to cancer or has cancer and is taken care of in the whole journey. And what that means is that when we're spreading out our resources, our financial resources, we make sure that Kenyans are protected or are covered right from the beginning. When we look at, let's say, primary health care level, where we are looking at mainly preventing, health promotion, and also being able to diagnose what can be diagnosed at that point in time, then those services are provided and they are covered financially at that level. So if a patient goes to a hospital, irrespective of what has taken them to the hospital, at this primary health care level, we are able to intervene and do even simple methods of looking out for some of these common cancers as they have been highlighted. So in our country, we know the cancers which are common, so we first target those ones with the resources that are available to us. Mm-hmm. We allocate enough to make sure that what can be picked at that stage is picked. Mm-hmm. And therefore, that is why the authority did allocate resources to make sure these cover the benefits that are covered at that lower level, are looking at that screening of the common cancers, be it breast cancer or cervical cancer, prostate cancer. So we have an intervention that is covered financially at that level. Mm-hmm. And even more importantly, the way the financing is structured is such that at the primary health care level, which is where care begins, this person or this Kenyan who is seeking this care doesn't have to worry about payments, because the primary health care fund, which is at the base, is funded by the government. And what that means is that those services that are looking towards preventing or managing cancers at a lower level, all Kenyans who have registered into SHA have access to those services. And that is something that we did not have before. So then now we look at it. Of course, we will do the best that we can at that lower level, but there are those ones now who will need services at a higher level. When we move from a dispensary, a health center, or a clinic, or a nursing home, or a sub-county facility, and something has been picked, or is an ongoing diagnosis that is already known, and the patient needs to be referred to either a county referral hospital or a national referral hospital or another private hospital of that level 4, 5, and 6, that there is still resources allocated there. So we are not now neglecting the work that we've done here at the lower level. We travel the journey financially with the patient to this higher level and make sure that if it is diagnosis that is needed, that was not available at the lower level, those diagnostic tests can be done now at this higher level. Mm-hmm. Once the diagnosis is done and the patient requires treatment, then that also is covered. And what that means is that the patient, that continuum of care is not lost. And that is very important as far as the financing mechanisms to protect and to support the patients who have cancer are concerned. And that is one of the areas that has really been paid a lot of attention to make sure that we are doing what we need to do to make sure that the patients are not left behind, whether they have the funds or they don't have the funds. All
right. So perhaps you can put some, I don't say dollar amount, but shilling amounts to some of these diagnostic tests, like how much is allocated to what. But we'll get into that. Mm-hmm. Because that was a major concern, I think, when the rollout first happened. Perhaps you can tell us what improvements and advancements have been made after receiving feedback from the stakeholders. But Dr. Oweng, I mean, you lost your grandmother to cancer. Your father suffered from cancer as well. Where your father was concerned, you went to India, as I heard you say.
Yes.
Many people you will hear are either raising funds to go to India. Why is that? Is it because we don't have enough specialists in the country? Is it cheaper? Is it the equipment? What are the factors that drive people to look for cancer treatment abroad, do you think? And also, given your experience.
Yeah, thank you. I think when it comes to the cancer experience, like we mentioned earlier, it is unique and specific for each patient. And in the circumstances of my dad, for example, it was that given his age and the type of surgery that he needed, there was a less invasive technique that was not available locally that we needed to be able to try. So because we assumed that that was going to have, there were going to be better outcomes. But the aspect of people seeking treatment out of this country is one of the biggest challenges that we have because, let's be honest, by and large, you've got a lot of people who also seek treatment out of this country for treatments that are available locally, all right? Firstly, it might very well be that they're not even aware that those treatments are available locally. Secondly, it might be that the cost is what is prohibitive. And therefore, when especially you're paying out of pocket and you are given a cost comparison, then it makes more sense to be able to access the care out of the country. And what I call this cross-border contracting of healthcare services is a big problem because, first of all, it denies our local personnel getting the requisite expertise. And surgery is an art as well as is a skill which is learned. And the more you do it, the better you get. So, for example, if I give you an option of having some neurosurgery with a neurosurgeon who has done only 2 cases, as opposed to another one who's done 1,000, you can see how you're going to lean towards having the person who's had more experience. So we're denying our people experience. We've got a lot of resources that we are sending out of the country, maybe when we don't need to. And what I would advocate as much as possible is enhancing our local capacity. So even when the expertise doesn't exist, we go into collaborative efforts where we get specialists to be able to come and work together with our workers, and therefore we've got knowledge transfer. So those are some of the challenges that we have. But going back to my dad's case, it is not unique, all right? And the cancer is very fair in that sense because it doesn't discriminate. Even doctors themselves get cancer, isn't it? So at the end of the day, it has to be that what we're trying to do, especially as the National Cancer Institute, is to make sure that we make this experience a bearable one at best, all right? Bearable one, because you cannot say it's going to be a good one, but at least one that we make that experience as good as it can be, given the circumstance. And that's why we're talking about the patient-centric. You asked earlier about the patient-centric approach. We are focusing on the patient and as a person, not as a disease. Because sometimes as medical personnel, unfortunately, a lot of the time, we focus too much on the illness. But there's a whole realm, any life-threatening illness that somebody is afflicted with has got a serious psychosocial impact, whether it's on their ability to earn, whether it's on their relationships, whether it's on their finances and so on. So all those things need to be looked at holistically, and that's why we're talking about patient-centered care.
Mm-hmm. I'm curious, Dr. Musau, yes. You know, just looking at Dr. Olwenye's case, the dad, by the time he went in for surgery, they were unable to perform the surgery because, as I understood it, it had, moved to his heart or?
Yeah, the tumor was adherent to his heart, yes.
To his heart.
Yes.
So when patients come to your office, when you're consulting, at what stage mainly do they seek out care?
I mean, we have a variation. There are patients who will come in because they fear they might have cancer, or they have a family member that has cancer, and so they want to be, screened for cancer. We have patients who come in quite early, who have just not got any symptoms, have gone for screening, and we detect that they have a cancer, and we confirm that they have a cancer. We have those that actually do feel symptoms and come in, and we still catch the cancer early. But unfortunately, there are many that come in with advanced cancer. And it's unfortunate because services are available. Of course, there are all the nuances regarding health financing and access regarding the distance and all of that. But services are available locally. And even amongst ourselves as oncologists, we were having a discussion saying it looks like Kenya will be the hub, south of the Sahara, north of the Cape. We are looking to be the hub because of just how much equipment and infrastructure that we have poured into the field of cancer, both in the public sector and the private sector. A lot of the patients actually do not need to leave the country. And more often than not, in the past few years, many who have traveled, when they come back, they are like, oh, so we have the same drugs here. We have the same management here. What you told me, doctor, is the same thing I was told over there. And so we are seeing a lot more patients being treated locally and not having the medical tourism that we saw in the late 90s, early 2000s. Mm-hmm.
Yes. And I'm curious, how do you reach those in far-flung areas where screening is concerned? Like, do you do, what would be the recommendation? Mobile clinics? I know telemedicine where treatment is concerned would make sense in some aspects. Mm-hmm. How do you reach those people, the people in the camps, people who have to walk long distances to get water, and for them, screening then is perhaps not a priority. Or rather, they're just not aware of these cancers and what their options are.
All right. So the biggest thing, especially for healthcare professionals, is the index of suspicion. They need to be aware that cancer does exist. It's not just the common communicable diseases that we see all the time. We have various platforms where, healthcare professionals at whatever level or whatever cadre can actually get onto online and learn about cancer diagnosis and treatments that are available. And we have one such platform at the Ministry of Health called eSaratani, and it's free of charge. They're able to log in, create an account, and they're able to learn. So that increases the index of suspicion of the healthcare workers, even in the rural healthcare setting. Further to that, we did have efforts to increase cancer screening or diagnostic capacity in the country. And so we had mammograms put out in the level 5 hospitals across the country, CT scans available, ultrasounds available, and those equipments can be help screening cancers as well. Of course, then comes the question of the personnel to be able to manage these equipments and all of that, but the equipments are available and they run. The other thing is referral patterns and referral networks to be able to ensure that a patient who has been suspected of having a cancer can be navigated through the system. And so navigation, patient navigators become very important in this journey. So it could be lay navigators, meaning that we could use the community health volunteers to be able to navigate a patient through the system, or we could use nurse navigators or clinical officers to be able to help navigate the patients through the system where they can actually access care, be it in a regional cancer center or a comprehensive cancer center, or even to the district, the sub-county hospitals where they can get curative surgeries for the early cases.
Mm-hmm. You have something to add to that?
Yes, if I may add to what my two colleagues have said. The solution here is not to do cancer screening and prevention in a staccato manner like what we're doing now, World Cancer Day, we go screen and so on. Cancer care must be integrated to our healthcare system at all levels. And this starts all the way from, and one of the initiatives that we are responsible for as NCI Kenya is to make sure that it goes into the training, so that every patient encounter for anybody who's at risk of cancer has to incorporate the aspect of screening for cancer risk. But of course, that also means that we have to resource them to be able to do that screening. Resourcing meaning also financing from different sources, isn't it? But it has to be, I am a firm believer in what you incentivize happens. And so at the end of the day, that's the solution. Because at the moment, the challenge we have is most of the time, screening is regarded as a very specialized activity, which is done by specialized teams reaching out, mobile clinics and so on. That's not the approach. At that dispensary, the first point of care, in fact, the foot soldiers whom we have now called the community health promoters are one of the first line of defense against cancer. Because they're the ones who are going to go out to the communities, much as they might not be very highly trained medically, but they can be able to ask simple questions like, when is the last time you have screened for ABC? And then make sure that these people can access facilities where they can have the screening done. But it has to be screening and it has to be paid for.
All right. Dr. Teresa, what packages are we looking at, for example, for diagnostic tests? I know you said the focus is on the major, the big 5 cancers, if I understood you correctly. Like those are the cancers that mainly affect Kenyans. And so are the packages geared toward those?
Thank you. In terms of the most common cancers, which I was referring to, it's the target at the screening level, because then it will not be cost effective to go screening for cancers that may not be that common at the expense of the ones that are common that you are likely to pick and intervene early. That is at the screening level. And even at that screening level, it doesn't mean that the other cancers have been neglected. While there is a prioritization in the benefit for that, also in the way the healthcare delivery is structured, there is still integrated form of financing in the entire healthcare system to be able to pick also these other cancers. However, when we come to diagnostics and treatment, we're not excluding. It doesn't matter that because when a cancer happens to a patient, it doesn't matter whether it is 1 in a million. To that patient, that is their life. And therefore, at the financing level, we prioritize all those patients who will come with the disease. And therefore, when it comes to diagnosis and treatment, then we look at making sure we have enough resources. As Dr. Musau has talked about some of those diagnostics that are available locally, you will find that they are included in the benefits packages. Whether it is you want to do an MRI, whether you want to do a mammogram, an ultrasound, a CT scan, laboratory diagnosis, tumor that are going to pick the cancers or just to follow up, all those you will find they are included in the benefits packages. And again, as has been said, when we look at treatment, cancers being very variable, they also require very diverse ways of treatment. So what the packages do is that we make sure that we have covered the modalities of treatment that are required for different types of cancers. So you find for some cancers, they may not require surgery, they may require radiotherapy, chemotherapy, immunotherapy, all those different types of treatment. When you look at the benefits packages, they are actually factored in. So then it is now aligned based on the treatment guidelines that are provided. Then those are the guidelines we use to make sure that the modalities that are recommended are the ones that we are covering with the resources that are available. Mm-hmm. So in case of treatment, even where you reach a point where a patient may require to be treated outside of the country, and it has been established that what they need is not available, also that is also taken care of. So when you look at it, starting from level 2, that is under Social Health Authority, although we also have level 1, as Dr. Musau has mentioned, in terms of even using the community health promoters, as a service it's still provided. We just won't talk about it because under SHA, because the funding is a different element, but as a service is also provided. So that means that this cancer care, in terms of financing, we are seeing finances allocated to cancer care, even cancer prevention, cancer control, everything from level 1 of care at the community level all the way to level 6.
Okay.
Yes.
You talk about receiving care out of the country, and many people are asking, the question is, covered to what extent? You know, what's the cap, 500,000? And, you know, does that cater for the type of treatment you get in some cases in India? So a lot of people are asking covered to what extent? Because SHA, we were told, is intended to save us from bankruptcy. Because sometimes your loved one is diagnosed with cancer and it wipes you out as a family. But we'll get into that. Let's get some feedback. So I'll put up in that. You got the question, yeah?
Yes, I did.
All right. Let's take a look at the feedback that has come in quite a bit. We have Vincent Ogero. What happened to the pledge by the Prime Minister of India to set up a cancer treatment here in Kenya to train oncologists with the latest state-of-art equipment from India, and why can't some be set up at KUTRRH to stop the medical tourism to India? I don't know whether Dr. Olweny, you would have the answer to that particular question by Vincent Ogero. You can see it right behind me here.
Sorry, I don't have any update on that, unfortunately.
Okay,
that I think is being handled by the ministry leadership, so I don't have an update on that as of now.
All right, so Vincent, Dr. Olweny says he doesn't have an update on that as of now. This is Scott Lagat, who says, what policies does the Kenyan government have in place to support cancer patients, and what more is needed? How can advocacy groups work with the government to ensure that cancer treatment is affordable and accessible to everyone? Do we begin with the first question? What policies does the Kenyan government have in place to support cancer patients, and what more is needed? You'll take that one, Dr. Olweny?
Yes, I think I already elucidated some of these things in the earlier discussion. The policies that we have in place, we've got various legislative framework, and then we've got the various organizations that are involved in cancer care. But you do appreciate also that we have got our healthcare system is devolved, and therefore you've got some rules that are part of national government and then the county governments. And so the national government does the coordination, it controls the larger hospitals, the level 6s, the KUTRH, MTRH, and KNH, for example. And then the county governments are the preserve of the individual county governments. So policy is in place, care is being provided, but of course, I've said there are challenges and there's a lot of room for improvement in terms of accessing that. The financing is being handled by the Social Health Authority. So those are the things that we have in place.
All right. Then there was a question about, let me see, how can advocacy groups work with the government to ensure that cancer treatment is affordable and accessible to everyone? Are you able to take that one, Dr. Musau?
Yes, I can comment on that. I also support the Ministry of Health in their technical working groups. And so I do know that they work together with advocacy groups and also patients, survivors. And so in the different Ministry of Health technical working groups, in terms of treatment, care and support, and survivorship and rehabilitation, we have representation from the different advocacy groups and even patients who are able to voice their concerns and voice the problems that they have directly to the Ministry of Health, and that helps to inform implementation of policies at the end of the day. We do have different policies. I mean, we have the Act, the Cancer Act, and we have the Kenya Cancer Policy, and we have various other policies, standards, and guidelines regarding cancer treatment within the country, just to ensure that it's safe, and of course with the oversight of NCI to make sure that the care that is being given is accredited and that is standardized across the country.
All right. This is Eddie Nyakiash, who says, one, what are the measures put in place by the Ministry of Health to address the concerns raised by Kenyans following an working Social Health Authority program? I'll leave that one for you, Dr. Triza. Number two, cancer is becoming a threat in Kenya's health. What mitigation measures have been put in place to address the menace which has been affecting the society for the longest period? So why don't we start with you, Dr. Tracy Joy? What are the measures put in place by the Ministry of Health to address the concerns raised by Kenyans following, Eddie says, an working Social Health Authority program?
Thank you for that question. As we're speaking, we know that this is an initiative that has been rolled out recently. And we're not even, we're almost just a few months into it. And being a new initiative that has been rolled out, we understand and we appreciate that a lot of good things have happened already. A lot of Kenyans who before could not access healthcare because they did not have money, yeah, or either they were not covered by any health insurance, or for whatever reason they didn't have that privilege, are able to access healthcare at no cost, meaning they don't need to pay because that has been taken care of with resources allocated. So a patient is able to walk into a facility, be treated sufficiently, and go home.
Okay, but what has been done to address the system challenges? Even registration was proving a challenge.
Yes, I was going there to say that before now we look at the challenges, understanding and appreciating that a lot of good work has gone in, and a lot of Kenyans are also experiencing something they have never had been able to experience as far as the financing and access to affordable healthcare is concerned. We have a patient who has walked into a hospital, they've been admitted, they have been treated, they have recovered, they have gone home. And others who have just paid their premiums, they've been able to access care that would ideally cost them thousands, hundreds of thousands of shillings. And now they're able to pay their premiums, which could be even be as little as 8,000 for the year, and they're able to walk into a facility, receive this care, whether it's a cancer patient or otherwise, and they're able to be treated to bills of hundreds of thousands or even more, and they're able to go home. That said, yeah, we understand that there are some challenges that have been experienced and have been resolved as or are being resolved as we are moving. So I would say that the important thing is to focus on where we've come from, where are we today, and where do we want to go, and how do we get there, so that when these challenges happen, the digitization project is there, and it is making a big difference. Work that would take a year to be done in terms of, let's say, visualizing what providers are claiming from the authority, being able to make those process and do payments. Those are things that could take months and months. But now this is something that can be done within a very short period of time. So when you look at it, a patient is there on the ward, they have been discharged, they need to go home. Now with this digitization project, with this process, you are able to launch into the system. It's visualized in real time, and it is dealt with immediately. And a lot of people have really benefited from that digitization process, and also the visibility, the data it is providing.
So what is this digitization of records, medical records?
It's not as simple as I would say. Digitization of the records is part of it, but it's bigger than that, because we are looking at having this digital system that is interconnected. Data is integrated from different systems, from different entities, and there is interoperability. What that means is a patient who goes to a health facility in Kisumu, the health provider at that level is able to request, let's say, for a test. Maybe it's a cancer patient who needs an MRI. The provider is able to request, it is put in the system, and immediately it is visualized, and an action can be taken immediately, because there is connectivity or interoperability and integration of data from where things like where we are talking about quality of care. We want to make sure that the people or the professionals who are providing care for these patients are qualified. How do you confirm that the patient, the professionals who is providing care is qualified? You make sure that the data that is collected by the regulator, let's say like the Kenya Medical Practitioners and Dentists Council and other regulators in the country, that data that they have, the registry, the licensure, is available and is integrated with the data system of Social Health Authority. So when I see somebody has asked they want, let's say, an MRI for this patient, or they have asked for a surgery, this system is able to fetch data from this other database that is housed by the regulator. And quickly you can be able to see, is this doctor a registered doctor? Are they licensed? Are they licensed to practice this particular scope that they have asked for financing for? This procedure they are asking, are they allowed to practice that? And quickly you're able to integrate all that information and make a decision that would have taken a long time, or even sometimes not be possible to verify before you offer this care. So what that means is you're able to track a lot of things at the point of care for this particular patient. If they require certain medication moving forward, you've integrated this system with the database that is coming from, let's say, Kenya Medical Supplies Agency. And you're able to check and say, okay, what medications are available? What do we have in the country? Where can it be availed? You can be able to track that and say, okay, so for this patient who is requesting for this service in Kisumu, maybe if they need to access this, this is where we need to send them to pick this medication, if, let's say, a patient has been diagnosed with a cancer somewhere at a remote part of the country, with this system that is interconnected, you're able to quickly check using the databases that are existing in other institutions, where can we get, let's say, a specialist or a cancer center that this patient may require.
Okay.
Yes, so all this, there's a lot of good in it, and it is making things much better, improving on the quality, accessibility, affordability, even transparency and visibility of data for real-time decision making.
Okay, let's take a look at some other feedback. Let's see, this is Kelkel Tonu, who's asking, are there early symptoms of cancer at probably stage 1, and what are the preventives? 2, are there any herbs found for treatment of any type of cancer? What are the causes of ovarian-related cancer and liver-related cancer? These are many questions. Is it necessarily to undergo oncology to examine cancer? Why aged people are most affected by cancer? Is it necessary to one undergoes oncology to examine the cancer? Why aged people are most affected by cancer? Should we start with question 1? Are there early symptoms of cancer, probably stage 1, and what are the preventives? Dr. Musau?
Most cancers, as they start out, do not have symptoms. They are asymptomatic, and that's why screening becomes very important. And for most of the patients that we catch with stage 1 cancers, you'll find that majority of them have actually undergone screening interventions for us to be able to detect it at stage 1. So unfortunately, there are no symptoms. Patients will be going up and about as normal. Many people imagine that patients with cancer come in with a lot of pain. They usually don't. Patients with, to catch it early, you need to undergo screening or early detection for us to be able to get it. In terms of
herbs found for treatment?
Herbs for treatment, I would not comment, as I am not a herbalist. You know, I leave that for them to comment.
All right.
Yes.
Number 3, what are causes of ovarian-related cancer and liver-related cancer?
Okay, I'll start with liver-related cancer. So for liver cancer, it has been associated with hepatitis B virus. And so majority of the liver cancers we see are hepatitis B positive. There are others that are associated with a condition called cirrhosis that could be linked as well to alcoholism. So people who take a lot of alcohol can get liver cirrhosis, which could lead to the development of liver cancer. For ovarian cancers, there are those that are related due to some genetic abnormalities. Like the breast cancer related gene could cause ovarian-related cancers.
All right.
Yeah.
Is it necessary to undergo oncology to examine cancer?
So once a cancer has been detected, so you have a suspicion of a cancer, usually you will utilize the services of a surgeon or an interventional radiologist to get us a biopsy. Then the pathologist confirms that this is indeed a cancer. At that point, they're usually referred to an oncologist who discusses the case in a multidisciplinary team setting. So it's not just the oncologist that needs to discuss a case of a person with cancer. It needs to be a whole team. So everyone that is involved in the diagnosis of that cancer and the treatment and management of that cancer sits at a table, whether virtually or physical, and is able to discuss that patient so that whatever treatment is given to the patient is actually personalized to that patient. It is unique to that patient.
All right. Finally, from Kelkel to know, why aged people are the most affected by cancer?
So cancers affect the elderly more. More genetic aberrations happen in the elderly population. And so we see more older people with cancers. But that said, we do have young people with cancers, and we do even have children that are affected by cancers. So it just also depends on the type of cancer that we're talking about. There are some that are more common in children, and there are those that are more common in a certain age group or even adults, elderly.
All right, there was the question prior. I think we just flipped over. Here we go. Moses Diru-Ambassa, I think you'll take this one, Dr. Wayne. We are told to go for screening, but those who are already affected and known, nobody cares about them. Imagine taking so long to be diagnosed, and treatment, CT scan, ultrasound, and MRI are too expensive for the ordinary person.
It's true. I do agree the situation with cancer is dire, especially in our environment where we are still diagnosing too many cancers late. So I understand his frustration about that. We're talking about screening, but at the end of the day, we also can't just take care of one segment of the population. We have to make sure that we prevent cancer and diagnose it early, at the same time as those who have got cancer also need to get the treatment that they can. But I do appreciate that cancer treatment is especially when diagnosed late, is expensive, and we have not reached the level where we want to be. And that's why we say cancer. Somebody mentioned earlier about cancer being a disaster, so to speak. And that is the reason why, because cancer causes a lot of pain and suffering in those who have got cancer. It causes a lot of psychosocial impact. It causes catastrophic health expenditure. And in addition to that, cancer is the third leading cause of death. So it is something that is being taken seriously, and steps are being made to ensure that we improve the care and, of course, look for ways of being able to fund that care. That's what is important, because in the absence of funding, I regard this as the oil that runs things. In the absence of significant funding being deployed, enough resources being deployed in that sector, it becomes very difficult for people to access care. And
what are some of the solutions then? Because government, they've told us, can only allocate so much, right? Kenyans are crying that we're already paying too much in terms of SHA contributions. Are there innovative ways to finance cancer treatment in the country?
Yes, they are. First of all, I said we have to move a leftward shift. In other words, we don't have to wait until we've got people at the later stages. The leftward shift in terms of prevention, but that has to be funded. And that was the thinking behind having the primary healthcare fund funded sufficiently, so that we can be able to have all these things at the initial point of care, the lower levels of care. So we're first of all catching them early, diagnosing early, and then funding it the entire process through the diagnosis and the treatment, and therefore even up to the end where you require rehabilitation and palliative care service. That was the dream that was supposed to be the shared dream in terms of healthcare financing and how we were supposed to change the healthcare architecture, financing architecture. We have not reached there yet. I think there's room for improvement. We have made a start, and I'm not, of course, very competent to comment specifically on what initiatives are being done of late, but I know at least that's where we're supposed to go.
Do you have anything to add to that, Dr. Musau?
Yes, maybe I can add on, and also leveraging on public-private partnerships to be able to ensure that, patients probably in the public healthcare system can also access services in the private healthcare system at an affordable cost. And we've seen this happen at the Kenyatta National Hospital, which has partnered with the Aga Khan University Hospital, and when the queues are too long at the Kenyatta National Hospital, the Aga Khan University Hospital will treat them at the same price as the Kenyatta National Hospital. So leveraging on such partnerships to be able to ensure that patients are actually able to access timely care, which will actually impact on outcomes at the end of the day.
All right.
Yeah.
Dr. Tracy John, I'll ask you to put on your doctor's hat for this next one. Hello, Olive. Could the doctors clear the myth behind biopsy that it leads to increased spread of the cancer cells in the body once the cancer cell is touched? Or would you prefer Dr. Musau takes that one? All right, go ahead.
Word Koyugi, thank you for calling it what it is, a myth. At the end of the day, we need to be able to diagnose the cancer. And so the techniques that we use to be able to get the biopsy do not allow for the cells to spread. If you go to a professional who knows how to take the biopsies, then they're able to be taken safely, and we're able to get a small sample of where the tumor is, and then that is analyzed to be able to tell us what type of cancer that we're dealing with, because that helps us know how to manage that particular cancer.
All right.
So it is just that, a myth.
A myth.
Yes.
All right. Thank you for busting that tonight. Here you have Vitu Moses Kadhumo. We focus a lot on cancer menace instead of how to prevent it, causes, caution, and our own funded research on how to treat it. So how about we start with prevention? Is there a way to prevent cancer? Dr. Musau, again, we'll come back to you.
Yes, prevention is key, and I think the gospel of prevention needs to be sung out a little bit louder. We can prevent cancer. Of course, lifestyle change is the big factor here. What we put into our body matters. Avoiding tobacco. Nicotine has been the single cause of many cancers and confirmed that it is. And so avoiding tobacco in all its forms, whether it's smoking, sniffing it, chewing it, and then, of course, avoiding heavy alcohol consumption, ensuring that you are at a good BMI, so making sure that you exercise. Some physical activity is good, and we have guidelines to be able to guide on how much physical activity you should do. Yes, and then, of course, getting your annual physical. Many of us tend to go to hospital when we are feeling unwell. We don't go to hospital when we are well to be screened and told our risk for certain diseases. And so there are different healthcare packages, wellness packages in the hospitals, including government hospitals, that can be accessed. And you can be given a full physical, tests are done, and you're given guidance on how to lead a better and healthier lifestyle based on your on the test results that you have, and also your family history at the end of the day.
All right. Monica, let me pull a Jeff. Jeff likes to call Monica. Monica, if you could just take a look at it. There was a second part to that comment. All right, quick. Okay, not to worry.
I think it was to do with the research.
Here we go. Thank you. That was the first one. That one. So how to prevent it, we've talked about. What about our own funded research? That's the bit I think I missed. Do you want to take that one?
Yes, there's a lot of research that is going on because a lot of things to do with illness also have got very different racial differences depending on and also different parts of the world. So it's important for us to have research that is specific to our setup, and therefore we know how our patients are what conditions our patients have and how they're going to respond to treatment. There's a lot of research which is going on locally. And I know, for example, KEMRI, even NCI itself funds research, in fact, gives grants in terms of people being able to research. So in summary, there is local research that's going on. There's still room for improvement because, of course, resources are limited, but there's research that's going on.
All right. Yes. So we've taken stock of where we are as a country in the fight against cancer. You know, as your last remarks, which way should we be looking? I'll start with you, Dr. Musau.
I think twofold. We should be looking more towards personalized medicine, where we're able to access, the latest technology in terms of treatments for cancer patients, be it targeted agents, immunotherapy. And then the second thing would be research, be it, research driven by the cases that we see in the environment that we see them, or be it clinical trials that we can be able to access standard of care treatments that we might not otherwise be able to afford for our patients.
Mm-hmm. Dr. Owen?
I'd say prevention, and then patient-centered care. And at the end of the day, let people go and get screened. As much as possible, let people go and get screened, and let us provide care that is patient-centered and holistic for that particular patient.
And, you know, when I was listening to your Engage talk, you talked about experiencing some callousness at the hands of healthcare providers. How do we address that?
I want to believe I was unfortunate because I want to believe that was an isolated incident. I don't want to say as a healthcare worker that in general we are not caring. And it was callous indifference to the extent that people were looking at my dad as a medical condition as opposed to holistically as a person who has got family, who has got relatives, who have got feelings. That's the insensitivity that I was referring to, but not in terms of the quality of the medical care that he was getting as such. It's just that they were not sensitive to the family. And one thing people have got to appreciate, especially as the illness progresses, in fact, focus sometimes needs to shift even more to the family members as opposed to the patient themselves. And that's where I think they missed the point.
Okay.
Yeah.
All right. Dr. Triza, Dr. Tracy John, we focus a lot on treatment, yes, but also what about, does SHA factor in the mental toll that cancer can take on a person?
Yes. When it comes to the care that is provided, it's all integrated. So at whatever level that the patient accesses this care, we are not just looking at, say, the drugs or the medicine or the surgery. We are looking at the whole continuum of care, making sure that if the patient needs mental health improvement, then that is incorporated into the treatment package and they're able to access that, and that is covered. So when you look at the benefits, you will see that mental health has been considered strongly. It is covered, it is allocated resources. When we talk about the package for mental health, we don't discriminate and say that this is mental health only for this type of mental illnesses. Any patient who requires any form of mental health then is able to access that package, and that includes patients who are suffering from cancer, whether it's counseling, whether they need psychiatric care, whatever form of care that is required to make sure that their mental wellness is taken care of, it is integrated and it's covered.
All right.
Yeah.
And of course, there's a question we left pending in terms of covered to what extent. For example, if I need to get treatment abroad, I'm covered to what extent?
To what extent? First, we look at it in terms of the cost of care, because there's a cost of care and then there's a price of care. So we look at trying to balance these two so that we have resources that can be available to the entire population, because it would not be cost effective to, let's say, cover the highest pricing in the market for a few individuals and leave the other parts of the population exposed. So we focus on what is the cost. What is the cost of this service that we want to deliver? Yeah. And once that cost is covered in the benefits with the tariff that is prescribed, then we look at now what are the other ways that we can use to also make sure that these prices that are there are able to come down, or the actual cost is able to come down to be able to use the limited resources available to cover more people. For instance, now with the Social Health Authority, with mandatory social health insurance coverage in the country, what it means is that now we can start looking at even things like bulk procurement of, let's say, medicine. And if you do that, do things like local manufacturing, which are initiatives which are also ongoing. These are areas that we can leverage on with economies of scale to make sure that we're able to get access to these drugs, let's say like for treatment of cancer, at a much more affordable cost, so that with the same coverage, with the same tariff that has been indicated, you can be able to cover a bigger population.
But you know, Dr. Tracy John, you've avoided mentioning specific numbers this entire conversation.
No, only for, why I have not mentioned the numbers is because I know those numbers are actually published and everyone can access the numbers. But more importantly, the reason is sometimes we focus on one intervention, on one figure, yeah, and then we lose sight of the bigger coverage. Because when you look at just one tariff, then you say, okay, this service, this intervention is this much. Then now we assume that that is all the money allocated to this patient. But this is the same patient who is going through outpatient care, is being covered from beginning to the end. They get admitted, they are covered in the inpatient, they are treated, yeah? They go through surgeries, and these surgeries are covered fully, yeah? And they get this treatment. The same patient requires more than one intervention. And then now these monies are allocated at different levels, because it will not make a lot of efficiencies to put all the monies in one intervention, pay the highest price in the market, and then leave this patient exposed. When they need surgery, we say now we don't have money for surgery. You may look like this one has reduced a bit, or this looks like it's not so much, but then you have another intervention that this patient needs that it is it is covered. So for me, I look at it like we have, if you interrogate the entire continuum of care from the lowest level to highest level that this patient who has cancer is able to access, and then now you put all these figures together, then you'll be actually surprised that it is a lot of money, yeah, running in probably even for some patients in millions that are covered. Yeah, so zeroing in on one figure may make us lose sight of the bigger picture, how all these things are playing together.
Okay.
Yes.
All right, so thank you very much for joining us tonight on The Explainer. We've had Dr. Helena Musau, and she is a consultant, radiation oncologist. She wears many hats. I'm going to stick with that one. We also had in studio the chair of the National Cancer Institute of Kenya, Dr. Timothy Oweny. Thank you for your time, as well as you, Dr. Tracy John, who is the acting director of Benefits and Claims Social Health Authority, and also Musimone Ivoivo, neurosurgeon. Glad to have that. We are happy to have hosted you this World Cancer Day. Thank you for your insights. My name is Olive Burrows. Our sign language interpreter has been none other than Njoki Sheye. Good night.